Hi there. My name is Dr. Denis, and today, together with Dr. K, it is our pleasure to present a new case in the ASAS Case Library. The case is case number 44, and this is quite relevant differential diagnosis for inflammatory conditions involving axial skeleton. As you see, this is 69-year-old male patient who came to us in the rheumatology department with a history of chronic back pain for quite a few years, with some inflammatory characteristics, including slow onset, back pain at night, with pain early in the morning with awakening, some morning stiffness, improvement of symptoms with exercise and not with rest. He has been diagnosed with psoriatic arthritis approximately 10 years ago, based on the presence of a personal history of psoriasis in combination with intermittent joint swelling. He has been treated with methotrexate, but couldn't tolerate it well and discontinued this treatment. And ever since, he was taking non-steroidal anti-inflammatory drugs. The symptoms, and especially back pain and some limitations in the spinal mobility, worsened over the last 6 years that warranted the current examination. At present examination, he was reporting ongoing low back pain, some arthralgias and intermittent joint swelling, no clear dactylitis or enthesitis history. As mentioned, he was taking in the last years on-demand NSAIDs with some pain relief. Importantly, gastrointestinal intolerance of NSAIDs limited its use, especially in the high dose, in the full anti-inflammatory dose. In terms of other spondyloarthritis-related manifestations, it is already mentioned psoriasis, but no inflammatory bowel disease and no acute anterior uveitis. And family history was rather non-contributing, and in terms of social history, he is a former heating technician, currently retired, and his amount of physical activity is rather limited. On the physical examination, he was in good general condition with BMI close to normal. There was some tenderness over spine and sacroiliac joints noted, as well as kyphotic posture. He had a couple of tender joints, but no active arthritis, no enthesitis, no dactylitis, and he had very mild psoriasis on his head. In the lab, HLA-B27 was negative, CRP was normal, ESR was borderline elevated. All other lab findings were within normal range. And now we'll review a few X-rays which were performed before the current examination and resulted into some confusion with respect to the diagnosis. Here you see a lateral view of the cervical spine, and what is quite remarkable in this case, this prominent new bone formation, really thick ossification involving several vertebral bodies. If you look at the thoracic spine, you see an ossification involving both left and right side, and also in the lateral view, you see this ossification. Quite importantly is that we see this small gap between the ossified ligament and the vertebral body that would be relevant for the discussion of the potential diagnosis. In the X-ray of the lumbar spine, you see also some breaching ossifications here in the thoracolumbar area, and already here you see that there is no high-grade sacroiliitis. Lateral view of lumbar spine, there are some changes which are undoubtedly of degenerative nature, Also here you see a breach. Here you see something where we could discuss whether it is of inflammatory nature or not. And there are also few other breaches we noted already on the lumbar spine. So the question after this X-rays and history still remained whether it is spondyloarthritis, for example, axial psoriatic arthritis, or whether it is a mechanical degenerative condition. And to solve this problem, we ordered MRI of sacroiliac joints, and it's my pleasure to give over to Dr. K to explain the findings on the MRI of sacroiliac joints.
Yeah, great. Thank you, Denis. It's my pleasure to now present the MRI and to work with the case further. We have here the MRI scan. The MRI scan consists of 4 different sequences, and we can see that the MRI examination starts with a T1 weighted fast spin echo sequence in an oblique coronal slice orientation, as it is recommended by the ASAS group, by the recent consensus-based ASAS protocol recommendation. In fact, the entire protocol quite nicely is adherent to this recommendation. And we start with analyzing slice number 1. And the first thing you do usually is to orient yourself in which anatomical location you are currently looking at the sacroiliac region. And here you see the spinal canal and the facet joints. So this makes us aware that this is the posterior aspect of the joint. So in order to start from the anterior aspect, you would first go to the end of the sliding bar to slice 21, and then go stepwise from the anterior slices that cover the pelvis to the area where we see the first slices that are touching or showing slices of the sacroiliac joints. And here are the first slices, so slice numbers 17 and 16, with some cortex that is a little bit dominant, maybe not really thickened yet, but it's a dominant, very thick cortex that is quite typical for the iliac bone. And we see this intermediate signal intensity here, which is the articular cartilage. As we go further into the joint, we can see that the contours of the sacral bone and the iliac bone, they are looking quite good. There are smooth contours of these bones. One might think, what's going on here with these smaller lesions or irregularities or signal intensity changes, let's say it like this. And we go further through the joint. We now can appreciate the full cartilaginous joint. We are now at slice number 9. And in slice number 8, we start seeing the retroarticular space with fatty cells and ligaments in between. So this is the transitional slice, where we start then going further into the ligamentous part of the joint that starts one slice earlier on the left side compared to the right side. So on slice 8, we have it just on the left, and on slice 7, we have it also beginning on the right side. And here already we have a full area here where we see the ligamentous area, which we then can see extensive to the posterior aspect. Also, what sticks to my eye is some high signal intensity here, close to the cartilage. There is some dark area here, which would be compatible with the cortex of the bone, that is this area. But still we have some intermediate signal intensity change here, which is compatible with the cartilage. So one could assume if this is some localized backfill sign with high signal intensity within the joint space. So a similar change is also seen here. So that's an interesting finding given the final diagnosis. So we have certainly something that we can discuss here in this case. So further, we look at the stir sequence. Again, we're starting at the posterior aspect, seeing the sacral canal going from the anterior aspect to the posterior area. We see no bone marrow edema whatsoever. So it's an inactive patient. There's no bone marrow edema, no osteitis. Maybe this is a small focus here close to the capsule. It's it's visible in 2 slices. So this is, if you see something like this, this is most probable a stress phenomenon at the posterior aspect of the joint capsule. Our third MRI sequence is a very important sequence. It's the 3-dimensional gradient echo sequence that usually has a high contrast between the articular cartilage and the bone. In this case, this is a wipe sequence, but depending on the vendor, it could be also a Thrive sequence or a lava sequence, or 3D quick sequence, depending on the 4 major MRI manufacturers. So what we can nicely see is that, again, it is not entirely smooth, the contour of the bone. If we look here on the right side, we can see that both the cortex of the sacrum and the cortex of the ilium, they are without any interruptions of the cortex line. Maybe smaller areas here where we can maybe see some calcifications inside the cartilage. On the left joint, however, we could assume some wavy contours of the cortex of the ilium. Here in this example, maybe also more here, smaller ones. And this could be, one could think these are erosions. The question is, are these true erosions, or are these just some irregularities due to the interface between the bone and the cartilage? So this is something that is needs to be discussed. And otherwise there are no erosions. But if we approach the entire joint, we can see one additional finding, and this can be seen especially if we approach the joint in the middle part, where we see the entire cartilage. We can see that at the anterior cranial joint capsule, there's no joint capsule, but there's bony bridging of the joint capsule. There's thick bone coming from the ilium to the sacrum, and the same is true on the other side here. So we have a bony fusion of the joint capsule, and if you compare it again with the T1 weighted image, we can also see here that there is bone marrow edema in this area. I think it's a little bit difficult to see due to the muscle with a similar signal intensity, but here you can see that this is some bony fusion or bony new bone formation in the joint capsule, and also here you can see it. And in fact, it is also a little bit going into the joint space here, as you see this. Our fourth MRI sequence is the stir sequence in oblique axial slice orientation. This is an additional sequence that is especially useful to distinguish the anterior from the middle and the posterior aspect of the joint. But as we don't have any bone marrow edema here, we do not need to spend a lot of time discussing this sequence. This patient was, for further clarification of the joint capsule ossification, especially to see if there are erosion evident, was undergoing low-dose computer tomography scanning. And here you see the low-dose CT protocol that was applied. We can nicely see the cortex of the sacrum and of the ilium. We see the ossifications of the capsules of both joints, almost symmetrical. There's a little bit pronounced sclerosis over here. And if we look very carefully, we can even see that there are some small foci of calcifications over here in the joint space. So that is something that is noteworthy, that we see these areas here not clearly cartilage, but there's also some calcifications inside. And this, on the other hand, might explain why we have the high signal intensity here, which we think is a backfill. So this leads to the impression that there's already some ossification in the joint space. And finally, maybe not for diagnostic purposes, but to make the library a little bit more interesting, we have this 3-dimensional reconstruction, what you can clearly see is that you cannot look into the joint. So there is ossification of the joint capsule, and that is something that is known in diffuse idiopathic skeletal hyperostosis or Forest-Days disease or DISH syndrome. And therefore, I think that this is the diagnosis that we are dealing here with a patient with DISH syndrome.
Very good, Kai. Indeed, we are facing nowadays an issue of frequent overdiagnosis of axial spondyloarthritis, and I think in patients with psoriasis, psoriatic arthritis, this problem may be even bigger because with increasing age, you nearly always see some signs of mechanical degenerative changes in the spine, some ossification there, and it is not always that easy to differentiate. What do you think about currently a discussed hypothesis that psoriasis may produce some extra spinal inflammation, so inflammation in the ligaments, which may not be well captured by conventional MRI of the spine, sacroiliac joints, and may ultimately result into ossification. So would it be a plausible explanation in this case?
So taking all this case together with the classical X-ray appearance of bony, bulgy, new bone formation, also capsular ossification, I think this particular case is very undoubtful, a case of DISH. But I'm aware of the discussion of the psoriasis, people who are dealing a lot with psoriasis, Krapper group, also ASAS members in favor of psoriasis and especially the axial manifestation. So we need to take into account that our diagnostic capabilities are already getting better. So I showed you these small foci of calcification in a low-dose CT scan. And remember, 10 years back, you would not be able to see this small amount of calcification on a CT scan, even with regular dose. So our technique is getting better and better. So we see much more, and I think, especially if you think about psoriasis, where a lot of enthesial sites are affected, that with modern CT and modern MRI, we will be able to see small calcifications at this area that we are not finding in the older textbooks, because medicine has evolved, and also technology in the field of radiology is contributing to better diagnosis. So I think the discussion needs to be done.
Thank you, Kai. I do believe that also in people with psoriasis, we need to exercise extreme caution interpreting imaging findings, and we need to be really sure that changes we observe on imaging are really of inflammatory origin, because this has crucial relevance for the treatment and for the optimized outcome in these patients. So this is pretty much it for today, my dearest friends, and please stay tuned. Thank you very much for watching, and you will see very soon next case in the ASAS Case Library.
And also a remark from me that you always can submit your cases to us. There's a link and contact email on the ASAS website, but you can also comment on the social channels of ASAS. They will reach out to us to look at this case, to prepare the case, maybe discuss the case, or maybe invite you to present the case. So this would be worthwhile if we would have 1 or 2 cases after the summer break from you, and we can broaden the discussion of these cases. Thank you.